Okay, so we're really lucky today that we have Ayesha and Shehnaz with us, and they're going to be speaking about COVID in South Africa, imagining responses that prioritize health equity and social justice. I think probably everybody knows both Ayesha and Shehnaz, but let me just do quick intros. So Ayesha is an independent global health policy analyst with an interest in health policy and its intersection with politics, economics, and the environment. She's widely published across international news outlets. So you probably have seen her pieces in Al Jazeera and TRT recently. And she's previously worked in the South African public health system as a medical doctor and is now based in Istanbul. And Shehnaz is a health policy and systems researcher and activist with a particular interest in feminist decolonial scholarship and praxis. She's been an occupational therapist for 10 years, working with vulnerable and marginalized communities in South Africa. Shehnaz serves on the steering committee of the People's Health Movement and loads of other things. She's currently based at WITS, and she's recently co-designed an initiative aimed at reimagining health systems, drawing on transformative indigenous feminist approaches to achieve health equity and social justice. So I'd recommend that all of you, after this, find them on social media, follow their work. They do really excellent and exciting work in this area. And yeah, and I'm sure we're in for a really exciting session today. So let me, with that, hand over to Ayesha.
Thanks for the introduction, Miktad. And also thanks for the opportunity. I think sometimes you want to research so many things, especially with focus on South Africa. And just doing a presentation like this has given us the kind of excuse to sink our teeth into some key issues. So we're going to be doing a general overview of COVID. There are so many things to cover and so many pressing issues in the South African context that we really wish we could have delved a bit deeper into certain things. But what we're going to try to do is give a broad overview. Discussion, depending on people's interests or depending on where we'd like to expand topics, we can take topics a bit deeper there. Just in terms of the overall outline, we're going to start off with some epidemiology trends. And this group was basically started around discussing epidemiology. So we felt that it would be prudent to just look at the disease from that perspective and see where things are headed in the South African context. Then we go on to the official response. What has government done in an official policy capacity? We'll talk a bit about the organizing committees around the National Command Council, Ministerial Advisory Committee. We'll talk about the state of disaster, economic stimulus plans, government solidarity fund. Key issues. I see this is our initial slide. We have added a few other issues later, but it won't affect the general outline too much. What were the immediate effects of the lockdowns? We talk about lobby groups, lockdown policy. What is interesting here is, I guess, this general outline could be transferred to other developing countries as well, because many of the issues tend to ring true, of course, with specific nuance. But yeah, it could be like a sort of a template to investigate or to analyze a broad systemic overview of COVID in various developing countries. We look at the disparities in experience and public discourse, vulnerable groupings, and this for me particularly, and I think for Shehnaz as well, it, well, she can talk about that. It has a particular bearing because we'll get into that, but vulnerable groupings is one that we'll place some emphasis on. We talk a little bit about the rural-urban divide, and then we go into community organization. Now, in terms of a way forward, I see Miktad, when he wrote the invitation, he put emphasis on that. But I guess that's what we all look forward to discussing, but this is the area around which we really need to be imaginative. So we have no solutions here, but we can outline the major problem areas and look at discussions which are emerging, and we can talk a bit more about that in the way forward. So let's begin. Shehnaz has some sections that she'll be covering in particular, but at any of the points, Shehnaz will probably jump in if she needs to add to mine, or I'll add to hers likewise. So it's the both of us that are going to be seeing this presentation too. So basically, let's start off. I'm sure nobody's seen this graph, right? It means nothing to anyone, right? So this is the famous graph that's been circulating in terms of when people talk about flattening the curve, this is what we are looking at. Now, interestingly, in South Africa, these models that the government is using to base decisions on have only been released into the public sphere around the 19th of May. And there's been calls from the broader academic community to have them released, but government was holding on to this information. And when they were asked why, the reasons that they gave was that they were trying to avoid public panic and stigma. So was it really this? Because to me, it seems like a bit of an empty sort of excuse. Why would you not release this information into the public domain? Because we know that having monopoly over the information allows you to control the narrative and to control the response. So I think there was a lot of pushback from other academics and from broader civil society saying, you are making these huge decisions. What are you basing your information on? And throw it out into the public realm so that we can all dissect and analyze. Because the more eyes that are on data, the more solution, or not solutions, but the broader the perspective can be. So eventually, government did release these statistics, these modeling stats, and what they have is they've got like a consortium, a COVID-19 modeling consortium, which consists of academics from about 3 universities. And this is your basic SEER model that they're using. But if we look at the graph over here, we find ourselves at around end of May. And if we look at it, South Africa is still on an upward trajectory. And this is an important thing to remember, is that we are ending the major lockdown right now. So we'll talk a bit more about the stages of lockdown. They started severe lockdown around the end of March. And this was one of the tightest lockdowns in the world. And we'll go into the reasons why they sort of easing up on that, but they're going into lower levels of the lockdown at the point when the disease is on an upward trajectory. So this is an interesting point of consideration. It shows that we have managed to delay the peak. Apparently, they have managed to flatten things somewhat. Just a few more graphs. The issues of interest here will come to the bottom left-hand side graph, where we see there's an optimistic prediction and a pessimistic prediction. And regardless of either, we still will not meet the minimum, we will go above the ICU bed threshold. And I think the total number in public and private combined is somewhere around 3,000 beds, but we'll come back to that a little later. Shehnaz and I were talking about this yesterday, and there's some ethics around investing in ICU beds and ICU care and high care in a developing world setup like South Africa, and the ethics around that in terms of resource allocation and which is the best way to allocate resources in such a setting. If we also look at the top right-hand graph, where we see the hospital non-ICU beds in reach, you see we will just be heading to the top of what we have available. Now, another interesting thing to consider is that during the lockdown, there was a ban on alcohol sales. And what this has done is it's actually freed up a good couple of thousand beds in the public sector, because South Africa has a very high correlation between alcohol use and trauma admissions. So this was during the lockdown, but again, we're easing up the lockdown right now. During this time, they're removing the alcohol ban. So I assume that it doesn't make too much sense. If you're keeping the alcohol ban in place, then why remove it now? And this will lead us on to issues around lobbying and policy. So just basically a review of what we have there. We could see anything between plus or minus 40,000 COVID deaths by November, peak during July or August. They do say that the lockdown is anticipated to have flattened the curve, delayed the peak for a few months. We likely to see a peak demand for hospital ICU beds in August and September. And there's a inter-province variation in terms of what we see. Just in terms of the absolute numbers, these are the numbers that I took off a dashboard, I think maybe about 3 days ago. So we're at around 524 deaths. And the testing, for me, the testing was very difficult to wrap my mind around because it was, okay, we'll go to that when we talk about testing. Just here, it's in terms of a provincial breakdown, we have 9 provinces. Am I right, Shehnaz? You muted.
Repeat your question, actually.
We have 9 provinces, am I right? Okay. Just checking. And we see that the Western Cape is leading in terms of death rates. Now, this is an interesting phenomenon, and people want to know, like, what is this? What is the difference in the Western Cape? So we're looking at the case fatality rates, and although it has a higher death rate, the case fatality rates in the Western Cape sort of align with the case fatality rates in the other provinces. So what's going on in the Western Cape? And there were a few theories that were proposed. One, the Western Cape obviously was saying, no, we're getting these numbers because we're doing so much testing and we're doing very targeted testing in specific hotspots. So that could make a credible case, but the counter to that is that what about your case fatality rate? So if you're assuming that you're going to increase testing in the other provinces, you would find you would assume to find increased deaths, but these are the death rates that we currently have, you know. So unless there's severe underreporting of death rates in other provinces, which is unlikely, we need to look at something else that would account for this Western Cape difference. Something else that was said was that, okay, then we've got to look at the Western Cape population. Is there anything about this demographic that affects what's going on with the virus? And this question arose because even with TB, we saw that there's clustering of TB in the Western Cape area, and epidemiologists trying to understand this for a long time. Why is this so? Is there a social determinant of health issue? Why is there increased clustering in the Western Cape? This is a theory that doesn't hold too much credence. So another theory is that maybe the demographic, maybe the lockdown was not complete here in the Western Cape. And the third theory was that maybe, and Shehnaz says she is more inclined to go with this one, was that other regions have yet to catch up. So it's making its way around, right? And then if we look at the age and gender trends, generally we seem to be following international trends in terms of the ages being affected and male predominance. Now we look at testing, and personally, I also need to wrap my head around the whole concept of community testing. There's definitely an issue with our testing capacity. In terms of the actual materials, so there's a backlog in the whole testing system because of getting our hands on the actual materials. Then there's a backlog. It's a very, apparently the type of test that South Africa does, it's the PCR one, and it's a very labor intensive one. So the turnaround time is very long, long comparatively. So it takes about anywhere between 5 and 12 days to get your test results, in which time the necessity of the test is actually invalidated, because what you want is, you want a fast test, you want tracing, if you want identification, contact tracing, isolation within that time span. And if we've got this long turnaround time, it kind of makes it a bit useless. So obviously there have been pushes towards getting different types of tests, faster tests. Now, what interests me,
on the ground, some of the reports have seen that, like, nurses in some of the government hospitals were infected, and they hadn't gotten their tests, but they were continuing to work. And that story entered the news, and there was some reports of a hospital potentially closing. So in terms of the turnaround time of the test on the ground, given the way that our population socializes and functions, it actually could be quite a real problem. You know, it depends on how it's managed. And if it was so poorly managed in facilities and came to nurses who were so forced the kind of draconian rules to continue working, that's quite scary.
Yeah, that's the on the ground reality. So just for a bit of context, Shehnaz would definitely have more insight into that because she's actually based in South Africa right now. My heart is in South Africa, but I'm based in Istanbul. So also just back to the testing. What confuses me, and maybe someone could shed some light on this or give some clarity, is that in the president's last address to the nation regarding COVID, he said something around the lines that what we've previously done is a broad-based community screening, and now we're going to go on to targeted testing. So to me, this seems a little bit counterintuitive. Either I've misunderstood it or I've misunderstood the process, because what the benefit initially is to go specific and to go hard initially, which is when you do your targeted testing broadly, and also simultaneously, but as a bit of a medium-term thing, you do your general community screening to get a sort of a feel for the trend of the disease. So if anyone comes across more clarity around that or can shed some insight, that would be a bit like beneficial. Now here we're looking at the infamous R estimates for South Africa. I see around the 29th of March, this is when we went into lockdown, and I think we've been maintaining an R of about 1.15. So if I understand it correctly, and maybe Mikdad can shed some light on that, as we go out of lockdown, things are going to change, or then it would depend on what kind of measures were put in place, but we can talk about that in the discussion. Now we go on to our particular, or my particular areas of interest. It's politics and the policies around us, right? So what we see here is there are two sort of overarching bodies. We've got the National Command Council and the Ministerial Advisory Committee. Now, if we look at the National Command Council, there's a bit of controversy around this this entity. What is, even South Africans want to know what is the National Command Council? Who does it consist of? And if in the visuals that come out of it, it sort of looks like, you know, when you see Obama and the Americans in this war room kind of thing. So you've got the president over there, and obviously everyone's connecting through Zoom calls. But on a deeper investigation, it appeared that the National Command Council was made up of some members of parliament, some MPs, some of the DGs from the various departments, and who ranked very highly up in this National Command Council was the security cluster. So the policing and yeah, these guys. So if you look at how this is constituted, you kind of see what has been given priority in terms of the policy response. So it's a very securitized, it's a very militarized response that is coming through. Now the Ministerial Advisory Committee, this is made up of your top scientists. I think these are like some of the best minds in the country. You've got clinicians, epidemiologists, all subcommittees, you know, research subcommittee, who are kind of advising the National Command Council. Now, the National Command Council has come under a lot of flack because of the lack of transparency with which decisions are being made. And they don't have the oversight that normal cabinet decisions would undergo. So, for instance, we'll go a bit more into this when we discuss the tobacco ban. and what the lack of transparency meant for this. In fact, there are about 2 or 3 court cases pending challenging the legitimacy of the National Command Council. Also, when we look at the Ministerial Advisory Committee, Shehnaz?
Sorry, but in terms of the National Command Council and the NAC, the civil society has submitted several letters asking for information about what's going on, also asking to just have a seat on the table. And a lot of those requests have just been ignored, unanswered, and we've been, civil society has written a lot of responses. So, it brought a lot of civil society organizations together, but it seems like it's quite politicized, and there's only people who are part of the SANEX group, which is a particular civil society grouping around HIV, that's quite powerful and that has kind of hands in with government, but doesn't represent most civil society voices. So it's quite concerning that they ignored letters and they haven't actually allowed other voices to speak. So it's not just other academics, other key thinkers in society that need this knowledge, but also civil society voices on the ground that have been lawyers, and this is like a range of the most important civil society organizations in health, and they just been left out completely.
And we'll come back to that very important point, like also towards the end, and when we talk about governance during this. And I think this type of clandestine way of making decisions goes a long way towards eroding a participatory democracy, which South Africa in theory is. So, and the reason why transparency is so necessary is because this has such far-reaching long-term implications on every part of society. So I think transparency around information and decision-making is a bare minimum, but that's my opinion. Anyway, we go on to the Ministerial Advisory Committee, and this is made up, like we said, of these top scientists. And an op-ed that I read said you wouldn't get all these top scientists that are such mavens in their field without having some sort of bickering or egos or internal squabbling. Which kind of has arisen, but the way I read it, and Shehnaz, maybe you can talk also more about this, is that some of these members on the Ministerial Advisory Committee have gone to the media to speak out around certain things. So for instance, there was the issue of Dr. Glenda Gray, who has impeccable credentials from HIV days. And she spoke out and said that the advisory committee members weren't being listened to. And she also made some remarks about the various lockdown recommendations and how nonsensical they were. She was shut down by the health minister saying she is a scientist who is responsible for the health element. They had to make these decisions based on balancing this with economics. So this kind of is not your domain, stay out. And it brings us to this issue of interdisciplinary collaboration. So you could have a multidisciplinary panel, each speaking different things and prioritizing your field of interest. So is that really like interdisciplinary? And we need, in order to address an issue like COVID, we really need a proper interdisciplinary approach. I see someone has raised their hand. Are we going to take questions at the end, Mikdad, or should we stop during the presentation?
As you prefer.
Shehnaz?
I know this, but in Rasul, you can tell me as well. Rasul is from the Rural Health Advocacy Project, and he's got a strong opinion about this issue of the so let's hear what he says.
Okay. Are you unmuted?
Okay. Yeah, I am unmuted, but I think we maybe carry on. But I think the important thing here is that there's still, and I think we're repeating this kind of thing about innovating experts. There's no experts in COVID, right? And there's no experts into figuring out where we're going to go and what we're going to do. Yes, there has been a bit of a concentration of power in the National Command Council. And I think part of that was informed by the fear or the anticipation of risk. And I think the things that we need to look at more or less is really how are the choices that we're making fair? And are the debates that we're raising really the pertinent debates at the moment? So I think I'm raising my hand on the issue of the tobacco ban and the rationality around it, and how it is, in a sense, a proxy for a broader discussion around whose voice is more important.
Sure.
Right. So when we look at the narrative around a lot of these debates, they're becoming proxies for a different kind of debate, where the 20% is dictating the policy that's affecting the broader populace. And I think the weird thing about the South African pandemic is, as it's moving out of the affluent areas, right? So our initial epidemic was concentrated amongst the middle classes, right? And that's when we instituted the lockdown, because we had these big fears about comorbidities that exist in the general population. So the big idea at that stage was, can we contain it? Just to be within those populations, and the bulk of the response in that first stage was in the private sector. Now we're moving into an environment where our epidemic is expanding into the community. And all of a sudden the discussions are changing around rationality. You know, so it becomes, the political debate changes to a blackness versus a whiteness, a privilege versus a group who are up to now voiceless. Civil society, in a sense, is also kind of problematic at the moment, because very few of us have direct links to communities on the ground.
For sure.
Right, and I think we're having some real challenges now. So my query now is that I don't think that the political economy of this thing is played out completely, and I think it's not useful to look at current approaches to regulations and attacking of the MAC without looking at the broader political interests in South Africa. But anyway, I'll continue to listen. But I'm just anxious that we questioning the legitimacy of the coordination and the rationality of the coordination, and sort of premising that on an argument of academic superiority. Right? Many of these people were AIDS activists as well. You know, I don't think that, and I think the whole issue of who is entitled to speak. When Glenda was in those meetings, she was quite fine, and she can defend herself, right? And our rules of law at the end of the day also protects her. So this massive outcry and villainizing of the state by academics is also something that needs to be included in the discussion around political economy and representativity, because who does the academic community respond to? Well, what is the basis of academic freedom if there's no peer review?
Sure.
Right? And why does one opinion masquerade as fact and another one come across as irrational? Purely because of who's sending the message. And I think it's a very, very complex space. But anyway, I'll listen.
Yeah. Okay.
I'm just concerned by the way that we're flowing around that.
Okay. Let's see if
the gender grey issue has become quite prominent in the media, but it has overshadowed the debate around who are the other voices that are just being ignored. So I think it is a critical point, and it does speak to how power plays out in the South Africa. So thank you, Rako, for that. Please stay on and come in at the end where we can have a discussion.
Yeah, like what I was saying, I hope we'll adjust some of that towards the end, and we can bring it together, rounding it off. Like for now in the beginning, I'm just trying to lay down just some of the facts, and then we'll go a bit more into the socioeconomic political analysis, and we'll round off. But let's see if it covers that. If not, we can pick that up again later. Now, in terms of the specifics of the lockdown, here you see this whole alert level plan. And under each plan, various sectors are activated and inactivated. And I mean, many countries have this. Even Singapore, you have under which level, which sector should be opened. But South Africa, at some point, took it down to a very nonsensical point where there was a ruling on which items of clothing could be purchased under which level of lockdown. So, I mean, this was criticized. We also talk about like the various levels and what is the actual enforcement capacity. Yeah, so like I said, now we're moving to a level 3. We'll talk more about that when we talk about the tobacco ban. Now we go on to the official response. The response was to instate the lockdown, create your various committees, and declare a state of disaster. Now, if you saw the imagery coming out of South Africa at the beginning, it was these boots on the ground, a highly militarized approach. In fact, I think, Shehnaz, correct me if I'm wrong, but the president even appeared in military attire at one of the speeches. So it was a very like, this is a war room, and this is the discourse that we're going to go forward with in terms of addressing it. So it was a militarized response instead of a very strongly like a response rooted in kind of social justice or social solidarity. Thousands of soldiers were deployed.
Of the military response also is quite gendered. I feel it's very patriarchal, and it doesn't really speak to the
yeah.
that we have. And I think that many people across the world have been complaining about it. But here we are. We have command councils. We have, the very much frontline workers. It's very much military language. And to me, it does lay the foundation for a later on where we might have this issue of health securitization across the world, around security of drugs, security of calling, people who are infected with diseases suspects. It becomes a scary world. So I do think we should watch out for that.
Yeah. So like you said, well, not necessarily there. It's like you're saying, laying the foundation, right? So it's something definitely like to guard against. And then why did we have this highly securitized response? And political and social commentator Stephen Friedman, and this speaks to the point that Russell brought up, he says that there's no dialogue between the various levels, like who speaks. Government is out of touch with its real constituency. They are the other, and we are the governing elite. So what is the only means of communicating or connecting with these people? It's control. We have no feedback loop. We have no feedback system in terms of a synergy between the larger, broader population and this governing elite. So the only way to control them is through a highly securitized response, which includes control. In fact, we had reports of severe heavy-handedness in the beginning. Especially, I mean, within the first few weeks of lockdown, it was things have changed subsequently, but it was very stark that there were 3 deaths from COVID, and there were 3 police incidents where people were killed because of police violence. And police violence is not something new in South Africa. We have the apartheid legacy. In fact, I think the way that our police are still functioning is because we haven't truly reformed the police force. It's policing the people rather than being a police force for the people. An incident was the case of Collins Kosa, who was a man in the township who was drinking his alcohol in a cup. And the police came in, and alcohol was banned at the time, and they beat him up so severely that he subsequently he passed away. And I know there's been court cases. I don't know the latest in terms of whether anyone was actually convicted, but I do know that the courts came down on the government to say, like, get these guys in line. They can't be behaving in this way. So maybe later on we can talk about like finality in that case, right?
And it really does speak to the lack of trust that, there's a state of complete distrust between the state and the community and community on the state, and it's quite a scary thing. Since 30 years on after apartheid, to have such levels of distrust is scary, and it does, create very concerning.
And we talk about the way that we speak to each other. And another academic, when we were having the student protest, was saying that look at what these students are doing to actually be heard. They're burning things, it's like they like kind of rioting just to be heard. But it's nothing new in South Africa. We have these service protest deliveries. Service delivery protests, where people like block the roads with like burning tires to be heard, because they are not being heard. So you need to do something dramatic to actually reach government's ears. And then too, in which way are you being responded to, right? I found a few very interesting quotes while we were reading up. And this one says that the history of policing in South Africa is a story of extreme violence. During the colonial and apartheid periods, the police and military were naked instruments of white supremacy. A khaki-clad, homegrown Gestapo focused on controlling politics and the movement of Black people. And nothing's really changed. It could just be that we've shifted a bit in terms of color, and now it's a bit more class-related, but it creates a very vivid image. And we also go back to looking at ways of controlling the population around times of pandemics or health insecurity. So the consequence, he's talking to people not knowing the history of uprisings and the history of pandemics in developing nations. And he says, it's actually a really nice article. I can give a reading list after this. The consequence of these incomplete archives still reverberate anywhere governments are drawing lessons from the colonial public health practice. The violence in countries like India, Kenya, South Africa, Uganda, and other settler colonies echoes the violence of the colonial state, in part because the successor independence governments read the violent colonial interventions as logical and necessary. So if we look to the archives, there's violent policing, which is seen as the natural and necessary part of a public health crisis response. And the successor governments don't question that. So here we come back to decolonization and how much we've internalized in terms of policing. It's not, the archive registers a problem, not as a violent state clamping down on a society that they have been brutalizing, but as the irrational resistance. And this is important, right? Also, I think to what Russell was saying, I think, but the irrational resistance of natives against the well-meaning efforts of a righteous colonial state. So the illusion that some violence is necessary to achieve public health goals because the native is inherently resistant to logic. It's inherited from colonizers and sustained because the archive is really critically interrogated. So again, you have the elite that know better than the uninformed native on the ground, right?
Can I just come in here and say that this plays itself out a lot in the healthcare system, where healthcare workers end up being the ones with knowledge, and the patients and the populace end up being the ones that are, like, you know, uninformed and bad, you know, just aren't able to take care of their health. So some sort of structural violence plays itself out in the healthcare system, and it's really created like years of access barriers, especially for the vulnerable populations and women, for abortion rights, for queer communities. But even just to get, even if you just on TB and you haven't been able to take your treatment for 6 months, if you're a defaulter, you get rapped on the knuckle. So this kind of, like, you know, feeling of being a bad patient is real, and the attitude, it's spoken about as attitude, you know, of the healthcare workers, and healthcare workers are sometimes villainized for having a bad attitude. But I think to me that's not useful, because these healthcare workers are patients in other contexts, and they also, we all have this, it's a structural, not cultural issue, but it's a societal issue where we really do need to shift that to be much more responsive to people. Yeah.
And it's a consequence of the biomedical model, which is also premised on hierarchies, right? So now we move on to the government's economic stimulus response. And to me, this is possibly the most challenging for me to wrap my head around. So we can maybe talk a bit more about it a bit later, just the specificities of it. So 500, I'll give you the broad outline, 500 billion is being set aside. It seems like a large figure, but analysts have said that once you actually look at where the money is going to, it was actually a large proportion of this was actually benchmarked for other spending and has been reprioritized. So a lot of the money that was supposed to go to infrastructural development has now been shifted into grants, you know. So it's like, you'll see there's a quotation coming up in the next slide. But then a lot of, so obviously a very immediate concern is unemployment. Here we see that 3 million jobs will be lost in the coming month, which is 3 times as many during the 2008 financial crisis. And worst case, job losses could be as high as 7 million. It's not conjecture. In our social circles, I've got at least 3 friends that I've seen on social media that have said, I've been laid off, you know. So it's a reality, and this is the middle class, you know. So what what they've done here is, on a high level, businesses are eligible for 0 interest loans, some tax breaks, unemployment insurance fund has expanded to prevent layoffs, so businesses can have some buffer. Good in theory. In reality, the bureaucracy in terms of kickstarting this process has obviously led to delays. And I was speaking to one economist, and he said that this is a big figure in theory, but how much will be accessed in reality is another issue, just because of the criteria that have been put forth. Then we've got the unemployment insurance fund going to those who are actually now newly unemployed. They've expanded this. No, but the question was, how do we reach those not in formal employment, right? Because we know that a large proportion of the South African population are in the informal sector. Oh man, I skipped a slide. Let me just go back. Okay, there we go. So what they said was, to reach this population, the most far-reaching and extensive grant that we have is the child support grant. So we're going to use this pre-existing mechanism. So fortunately, the South African state has access to vast social grant infrastructure. This was post-1994. That allows immediate reach to most of the poorest households, and it already distributes around 18 million grants every month, of which a large proportion is childcare support grants. And I think this goes a long way towards helping families, although of course there's critique that this is not enough. So what government did was they used these pre-existing structures to do some top-ups, but civil society organizations that are analyzing the absolute numbers say that this is still inadequate to ensure food security. Now still too, okay, we've reached these people outside formal employment, but there's still others who are impoverished. What I was reading about was that you've got a large proportion of unemployed young people that obviously that don't have kids of their own, so they don't fall within this child support bracket. And what government has done is they've got a COVID-specific social relief distress fund, which gives people 325 rands a month over the next 6 months. So here we go. Of the 4.5 million people who have applied, only 2.6 million people have verified. And in more than 3 weeks since its inception, only 10 people have received the grant. But I think stats might have changed by now. Moreover, the grant itself amounts to less than a loaf of bread per day. So if you look at it, it amounts to less than 20 USD. And that's about 16 pounds for the month. People are lining up, queuing up outside grant offices. Obviously, like social distancing goes to pot there, you know, so people are lining up, sometimes sleeping outside the offices just to get this 325 rands. It's an indicator of the level of desperation that many of our people are facing. But now, even after this, there are still people who fall outside this umbrella in terms of the social safety net. And who are these people? These are largely migrant populations, asylum seekers, and refugees. And while South Africa is obliged to care for refugees, in our public discourse, there's been a lot of xenophobia coming out of very prominent, the mouths of very prominent public figures. And the xenophobia also plays out on the street level. So this is back to what I was talking about. The government will take away 230 billion from infrastructure spending in impoverished areas with one hand, and give back only 50 billion in social grants with the other hand. So the impoverished will get a social relief of distress grant for 6 months, while the quality of basic public services in the area will continue to decline. So this is from an op-ed written. Also, government has gone on to giving out food packages. Communities on the ground say that they haven't really seen much of this. And the distribution of food packages is highly politicized in South Africa, with some reports that that people are handing out food packages along party affiliation lines, that some local municipality or ward councillors are stockpiling the food and distributing it to their personal patronage networks, right? Then government also has the Solidarity Fund. The president stood up and said, like, we call on big business, we call on private donors to please contribute to support government's efforts. And on the whole, like I was quite scathing of this because, and I spoke to one of my friends, Mariam Javeri, Shehnaz, like, she was looking at this and we said, like, how are private individuals or families or entities able to make these large donations, you know? And then someone mentioned, like, we should question how are they able to amass such wealth in the first place, you know? Practically, we have a friend that has been dealing with the Solidarity Fund, and it's rapidly, he says that it's rapidly increased availability of PPE. It's given some food support to the most dire areas, assisted with screening and preventative measures. So it's just like this stopgap short measure. But I see internationally, there's a call towards private donors and donations. And is this really sustainable? I mean, we shouldn't rely on the benevolence of random philanthropists. Then Shehnaz also mentioned, like, she'll talk a bit more about the wealth tax a bit later. Now we move on to key issues. The lockdown effects, like I said, it's one of the strictest in the world, but we didn't have adequate social safety nets. And I put this word resilient, it's a bit like annoying, but we don't have a resilient economy like some of the other Asian countries, you know. So if you're having these very tight and stringent lockdowns, what mitigating measures did you put in place, or did you think it wasn't necessary, or did you not give thought to it, you know? So we have a context in which households are one economic shock away from falling into an almost irreversible poverty. And like I said, they put in the unemployment insurance fund, etc. Right? So we had immediate unemployment because the informal sector, a lot of wage workers dependent on daily wages from a functioning society, and society kind of shut down. One of the saddest and cruelest things that COVID has exposed is food insecurity. And it's not just in the developing world. We see that in the UK and in the States too. Well, I think we'll have to reassess the concept of developing world after all this, right? And hunger has been, was an immediate concern. People were just hungry because they had no food because of people living in a hand-to-mouth existence. Also, they've been seeing increasing levels of malnutrition. We do have malnutrition in our hospitals, but they've been seeing increasing levels of malnutrition, although malnutrition takes a while to play out, right? From a public health perspective, there was sort of a pause on elective cases, on general medical treatment. So whereas we know the necessity of HIV treatment being regular, TB treatment being regular, we had like long gaps and pauses in this because of COVID. So I think once things start kicking in again, we're going to see a tremendous load on the health system. We know from our experience, Shehnaz, when we've had a few of the shutdowns previously during the big public sector service strikes, when things sort of ease up for a while and when we return to normal, it's a bang. And this is without even considering the impact of COVID, right? Now we go.
I think, Ayesha, just to say, you know, like, I think the biggest thing about the lockdown is that it actually is a lockdown that helped to get kind of, you know, rich people in their doors, but poor people couldn't actually lock down. And, you know, it really demonstrated the stark inequalities in the country. And I think it's similar in India, as we've heard before, that, you know, those that could afford to stay at home kind of romanticized this idea of lockdown and, like doing their breathing exercises and, cooking and
So we all went through our own existential crisis, Shehnaz. It was...
That's true. But I think the reality on the ground is that it didn't actually, it was an impossible ask for a lot of the people of South Africa. And it just created a lot more stress and anxiety. And I think that that's something we just, need to think about. Like, how do you actually contain, and I think it comes to the issue of Strandfontein as well, which we'll talk about later.
Maybe okay, you don't want to bring it in now. Okay, we will talk about it later then, right? So now we go into this key issue of food and water security, right? Before COVID, we had about 50% of households living under the poverty line. Pre-lockdown, we had 8 million people living in food poverty. Interesting to know in South Africa is it's not unavailability of food. It's not that food is unavailable. We have the food, but majority of our people can't afford it, right? Very immediately, incomes were devastated. And because of having no feedings, a lot of kids were dependent on school feeding schemes. So they estimated now that people living in food poverty is around 13 million, right? Before schools were closed, about 9 million learners received their meals through the school's nutrition program. And even then, more than a quarter of children under the age of 5 suffered from stunted growth because of chronic malnutrition. Like I mentioned earlier, there was this politicization of food distribution. Here we have the Abahlali Machandolo, I hope I pronounced it correctly, and this is the Shack Dwellers Association, which are very, very vocal advocacy group of people made up of representatives from these informal settlements, and they're known as the red shirts, right? So, for example, one of the members said that there are cases where ward councillors and ANC branch executive committees have had the names of well-known members of our movement scratched off the list of people due to receive the vouchers, the food vouchers. They make it clear that if you're with the red shirts, you will not get support. Shehnaz, you want to go into food prices?
You mean more on this? No, it's fine. Carry on. Here. Food prices. Sorry, I didn't realize. Moving to the next slide. Yeah, it's just there was an article that came out that really just looked at the fact that families in South Africa now are actually paying like 30% more on food than they did 2 months ago, and that's quite scary. So we had the lockdown. We had so many homes that are struggling for food, and here the prices go up. And you can see on the slide, like the increase on vegetables, increase on core staples. And so it's actually another injustice, and is stressing out, a large population of the people. Yeah.
I think this came at a very volatile time for us. Like if we're looking at the macroeconomic situation, I mean, we were having discussions with the IMF around taking out loans. Real wages had decreased, unemployment's on a high. So, I mean, it could have maybe come at a better time. Then in terms of what,
just before you go on, if you go back a slide, you can also see that the quality of the food that most people eat is also not as nutritious as we would like it to be. So, it's like maize meal, rice, flour, cooking oil, potatoes. And so, it just speaks to the broader question of non-communicable disease burden that we have, and how, this burden of overnutrition and undernutrition is exacerbated in our country, pre-COVID. But now, these things are, it's just another level. So this is going to be yet another burden of unmet need that we start to face.
So I think, I think we're in for some challenging times. Also, when you're talking about the nutritional content, apparently one of the advocacy groups also did an analysis of the content of these food packages and found it to be not necessarily a wholesome nutritional package. It was high in carbohydrates, but short in things like vitamins and proteins. Right, now we talk about water. We how many years into our bright new democracy, Shehnaz? I don't know. Anyway, post 94.
Almost.
And we still have a lot. Yeah, we still have a large proportion of the population that does not have access to clean drinking water. So we still have people, Going to rivers, which we see in the Eastern Cape, people are getting their drinking water from muddy rivers. For the past 6 months, they've been appealing to government. Now during COVID, apparently a lot of water tanks have been delivered to areas, but unfortunately the water tanks don't have water in them. Another perspective that one of the members from the Shack Dwellers Association brought up was that they've been asking for these things for so long, and to see government actually deliver it to some extent shows that government does have the capacity if it has the willingness, right? So I saw the provision of water and sanitation. Within 3 weeks of the lockdown, there were water tanks and sanitation rollout on a massive scale that we've never seen before. And I thought to myself, within 3 weeks, government's been able to deliver so much. What has stopped them from delivering to people who've been struggling with simple basic services all along? That's a simple question. Right, we go on to Russell's issue of the ban on the tobacco and what this highlights and whose voices are actually being listened to. So initially there was a ban on tobacco. One of the ministers cited reasons that smokers have an increased risk from COVID, and the way in which, well, I don't know if only South Africans, but in which some South Africans smoke is you share the, I don't know what's the terminology, you share the cigarette between you, kind of a thing, you know? So she said sometimes the way tobacco share doesn't allow for social distancing, but it actually encourages the smoking of the virus. So there was this ban on tobacco. Tobacco lobby groups, they're so well organized. I think these guys are amazing. Just, you got to hand that to them, right? So they called for lifting of the ban because they said that it was harming small business. And what Shehnaz and I were talking about yesterday was that just take a look at these arguments, because these are age-old arguments when people call for bans on tobacco or curtailments in alcohol. And I mean, it's very real ethical issues that we need to talk about when we talk about the harms of tobacco, right? Increased black market sales, which we've seen happening already. One guy like bought a box of sawdust. He was so disappointed and he said, you know, now I'm going to quit smoking. I'd rather spend my money on sweets because sweets aren't banned during the lockdown, you know? Then there's losses in tax revenue. And admittedly, it's a significant amount that government does get from the tobacco and alcohol industry. The controversy around this was initially there was a ban, then the president himself announced lifting of the ban, but then the minister, one of the ministers again said, no, it's actually banned again. And the tobacco lobby has taken this decision to court. But this back and forth on the policy means that the tobacco lobby has a strong voice, you know. Then we come on to the ban on alcohol. And I saw an article this morning saying that around, I think between 12 and 18,000 jobs, 8,000 jobs have been lost in the wine industry because of the lockdown. And I mean, like the wine industry, we're looking at the Cape perhaps. And I mean, these are already impoverished families now falling on, falling off the employment grid. It's a very real issue. And if you're calling from a public health perspective for curtailment or bans on these industries, again, you're going to have to look at mitigating measures. They banned the alcohol because of domestic violence with families being locked down, the fear of that. Shehnaz will talk a bit more about domestic violence. And like I said, South Africa has a terrible history with alcohol because some of our workers back in the colonial days were paid according to the tot system. So you do your work and you get a tot of liquor or wine, you know. And this creates alcohol dependency. So there's a high, and we know our trauma wards are packed to capacity on the weekends just because of alcohol-related violence, you know. So like I said, during the lockdown, they managed to free up about 5,000 beds. And look at this, the admissions went from 34,000 down to 12,000, just trauma-related admissions. Okay, but now we've got the lifting of the alcohol ban, and there's sales during certain hours or weekdays during level 3. So I don't know how this has been calculated when now we possibly probably going to need those extra beds. I don't know how that's been considered. Okay, and another contentious issue was religious gatherings. Religious gatherings under the previous lockdown stages were banned or prohibited. Now in level 3, there's religious gatherings up to 50 people. And there's been intense lobbying from certain communities, including the Muslim community. Now, I don't know whether members of the Muslim community, some of the members believe that, like, your religious fervor is like tied to how much you're going to lobby to go to the masjid, because these are usually small spaces, and the demographic that goes like a lot of the time elderly males. So but what's been impressive is that many masjid committees have looked at this easing up and have considered prioritizing life and have decided not to reopen their specific masjid. So I think this was quite an informed decision on the part of some mosque boards. Moving. Now we've got education and school closures. Generally, even before this, South Africa has had massive issues with education and with inequality in education standards. The inequality plays out on an immediate level. We see who's able to continue with their schooling are those kids and families who have access to online learning platforms. And one source mentioned that nearly 90% of all households in South Africa are still without access to the internet at home. To me, it seems like an inflated number, but it's possible. More than 80% of public schools are under-resourced. This is generally, not just now. And because of the overcrowding, problems with water, problems with sanitation, now that schools are being opened, you wonder how people will be able to manage the infection under such conditions, although we do know that children are not big spreaders or carriers of the disease. I mean, like teachers are still at risk. So it's going to be, again, you're working within a context of uncertainty. In fact, to talk about the sanitation problem, Shehnaz?
I mean, just to say on the ground, there's been like a flurry of a lot of like Zoom calls and meetings and like just a lot of people looking for support. How do you actually support students going back to school? So, you know, it's created a lot of anxiety. Parents are so confused. They don't really know what to do. And like I've already been asked like a few times, do you know someone we can speak to? Do you have a psychologist we can, you know, speak to? I've seen, you know, conversations amongst my friends even. So I think it's definitely a major concern. But what really does strike me is that when the lockdown happened, some of the private schools, and I know this because I have a friend who's a tutor, and she does additional lessons outside of school. So students come to her, and she was saying that the students that come to her for extra lessons from the private schools, they reported that they just went, you know, into school. They collected like a lot of their stuff. They went back home, and the very next day, school continued online, and they didn't miss a day. They didn't miss a lesson. They missed nothing. Whereas those students that come to her that, you know, really struggle or just go to a normal school, they've been very compromised. So the inequities are just playing itself out once again. And for students, for example, there's a school where, you know, top students that can't afford to go to schools, Ayesha, you know, Raucol, right? It's a school that caters for these top minds, but they come from poorer homes. They've been, you know, their education is now compromised. So I think it's going to be a major issue, and I really don't know how the Department of Basic Education is going to manage it. And the sizes of the classrooms have been an issue. Delivery of textbooks has been an issue. Aisha's going to talk to that later. It's really quite bad.
Like, I mean, you're going to need social distancing measures and PPE. We're going to need masks. If we're struggling to deliver basic textbooks to our schools without this issue of corruption and non-delivery, I really hope that we'll be able to overcome it by providing like basic sanitation. I know some schools don't have running water supplies. Recently, there was a story of a learner who died when he fell into one of these pit latrines, Shehnaz.
Yeah, this, I mean, it's been a long court case that Section 27 has taken up, but the student died. I mean, and it's been, the reports of, you know, students in rural areas having to walk for miles, walk across fields to get to school. I mean, these issues are real. So it's quite it's common, but the thing is that there hasn't actually been significant solutions to these issues.
Yes.
In schools, and now we sit in a COVID era, and these things have just been amplified.
Exactly.
So yeah.
Okay. So now we go on to vulnerable groupings. We have the homeless. There are many, but we've classified as the homeless, those in informal settlements, and the migrants, asylum seekers, and refugees. Shehnaz, you want to start with the homeless, perhaps?
Well, I mean, I think, just Strandfontein was a space just outside the city of Cape Town. Actually, my brother-in-law is from Strandfontein, but they had set up this camp where homeless people across the city were supposed to be housed. And it was quite an issue because they put these homeless people in there, and there were some reports that homeless people were not allowed to leave, or they were allowed to leave. And the conditions in the camp were incredibly bad. So people from the MSF went in, and they described it as just a violation of human rights, and also a high risk for COVID infections. And there wasn't enough psychosocial support, food, sanitation, and so forth. So they were just overcrowded, and it was really bad. And eventually there was this kind of court order to close the camp. So the camp is being closed. But to me, what's more concerning is how could the Department of Western Cape imagine a space like this? How could they even think of this as a solution for these homeless people? And how can we...
I'll challenge you there. Do you think they were actually looking at it as a solution for the homeless people, or was it a solution to protect the privileged people from these homeless people, infecting, sort of like the segregation based on like a hygiene principle? You know what I mean? Was it actually set up in their interests, kind of?
No, of course. I mean, of course, I think it was an experiment, a human experiment. And Cape Town is notorious for trying to, I mean, even just the old ancient communities in Bokap. Over the years, the city of Cape Town has, looked at Cape Town as a tourist hub, high property areas, and they've raised rates and taxes in an effort to try to push gentrify areas and push the poor to the margins. So this is just another thing. And I mean, recently I've been going to Cape Town and quite frequently. And my friends who live there keep telling me that there's more and more homeless people living in the streets. And it's actually really bad, given the stark inequalities. I mean, Cape Town's a beautiful city. There is so much money there. And even like there's a farm area in Philippi where, that land is like an aquifer. And the city has been trying to develop this area instead of allowing fruits and vegetables to grow. So, even in this COVID times, the city of Cape Town has tried to end the mosques from loud prayers, So there's a very different agenda, like the DA government in Cape Town is something, they if you look at even their reactions to COVID and their like smart solutions, it definitely is a different political animal. And
people call it the Republic of Cape Town, right?
Yeah, so I mean, Strandfontein is actually it's obviously not in the interests of poor people. But how could it happen? How could it how could we do this in the first place? To me, is actually just a question that I have.
Sure. Yeah.
I think we should go faster because time is.
Okay, let's move. Okay, now going on to informal settlements.
So this is just also another slide just to show, for example, the slide, if you go back one, Ayesha, it's just in Gauteng, the recent statistics of the homeless shelters that have been developed in Gauteng. But I will just have to look for that. Yeah, so in Gauteng, which is now the province that I live in, there has been quite a few temporary shelters being set up. So I think, you know, the situation in Cape Town is one thing, but there are other efforts across the country. And of course, this is an official government report. So, you know, but they say here that 3,126 homeless people are provided 3 meals on a daily basis with psychosocial support, medical assistance, and treatment for substance abuse. And to me, I feel like a lot of the time, these efforts happen on the side, but they don't often allow a lot of support from civil society to enable these things to happen. So you get all these, like, you know, separate setups to kind of like take over what government's meant to do, these NGOs. Sure. And NGOization of South African society is a real issue. Yeah, anyways.
Sure. Okay, so then we're moving on to informal settlements. And I think this statement by one member of the Shack Dwellers Association is so powerful. She says, disasters like fires and floods always affect impoverished people the most. For this reason, we've been saying during these years of struggle that disasters are political. Disease is also political. Class determines who has medical aid, who does not, who has access to water, sanitation, and safe means for heating, lighting, and who doesn't. We've reminded all our members that access to life-saving medication for people living with HIV was won through struggle and the politicization of an important health issue, right? It's vital that we politicize the crisis caused by the coronavirus and that impoverished and working class people take their place in this process. And again, when we're talking about homelessness, when we're talking about how the city is constructed, sorry, I'm just going to move to an area where I can access my power source. When we're talking about this, we have to talk about it in context of the geospatial apartheid that there is still a legacy of apartheid. I mean, we haven't properly addressed this, and the effects of it are still playing out. So this, and the way in which the spatial segregation was, okay, that's going to go into something a bit deeper. And interestingly, during this time, there's been continued state demolition of the informal settlements. So whereas people need places to lock down into, the state is still going ahead with demolishing these informal settlements. The minister is talking about de-densification. It would be very interesting to know what this actually means, because in the past, when people have been taken out of informal settlements, they've been moved to slightly remote areas that are now further away from their places of employment. So living costs, transport costs have gone up for them. Sometimes they've had to leave their places of employment, and also those dense and intricately woven social structures that were built on in these informal settlements were sort of uprooted, right? So de-densification would be an interesting thing to see. What do they actually mean by that, right? So that's one thing about the informal settlements. And now we have migrants, asylum seekers, and refugees. And I think the issue with this is a global one. We have this global underclass that are shunted between countries without the rights that are conferred on you by citizenship. So there are these vast numbers of people in South Africa, who usually from other parts of Africa, that have no documentation, no assistance. But what we see here is these are very resilient groups who self-organize, and they want to be employed. And if you see the groupings, like there's a Somali grouping in Mayfair who are now feeding other African nationals. And the issue is not just that they are now without employment because of the lockdown, but also they are unable to send remittances to their countries of origin. And what we see is many migrants have fallen through the cracks of government's response to the food shortage that many are facing during the extended lockdown. Government officials made it clear they'd only provide food to those who have legitimate permits and identity numbers, leaving thousands of people vulnerable. And when we talk about trust and how many South Africans have an issue with trusting authority, I think the issue with these migrant populations and trust in terms of coming forward to official structures, they have very little reason to trust authorities. This brings us to the question which we can talk about at the end around citizenship. And around under whose protective network or even identification do these people fall under? This global underclass shifting between places. We see the Rohingya, we see Syrian refugees. Thank goodness they have some place here in Turkey with some rights. But it's a philosophical question. If we're functioning under the premise of nation states, where do these people fit in, you know? Or do they fit in? Then I didn't delve too much into this, but there's still, because of the spatial apartheid legacies, we've got this large rural-urban divide that existed previously because blacks were shunted to the homelands, and this has never been properly addressed. So it's still contoured around apartheid spatial divide, and it's gone on from a racial divide, it's gone on to become a class divide. And here we have socially embedded power imbalances, which are mirrored in the spatial relations. There's a very interesting paper that I came across, and like I said, I can share it with you later. So these wounds, which are the pernicious effects of colonialism and apartheid, are painfully evident in the country's divided spaces. Shehnaz, now we're going to go on to PPE. Shehnaz?
Okay, so I think one of the major kind of health systems issues has really been access to personal protective equipment. And I think it's obviously a common problem everywhere in the world, but I just saw an article where some of the nurses are saying that in Gauteng complaining they don't have personal protective equipment, and in some cases their managers are forcing them to work without it. And other managers are using these kind of draconian tactics, such as issuing them with warning letters if they refuse to work without PPE, you know. And there's also seems to be some sort of a reluctance to test nurses. Obviously, this is different across the country. And, you know, so what do these things mean? And then also when it comes to community health workers, government has named community health workers from the very start as part of this response to increased testing and tracing. And they've been quite proud of naming community health workers as their kind of foot soldiers. But they haven't actually paid attention to the historical, you know, overhanging issues that community health workers have faced. And this includes PPE as just one of them. And on a webinar the other day with talking specifically about the issues of community health workers, one mentioned, I think she's from the Northern Cape, she said that, you know, one of her colleagues in February died from having contracted TB. And the state, you know, basically said, well, we don't know where you got this TB from. You could have got it from, you know, your own family members, you know, sort of denying the fact that she actually got it on duty. So PPE is not actually a new issue. And it also speaks to how COVID has become this kind of, I call it a celebrity disease, because it's now, you know, on everybody's minds. But these community health workers have been facing, you know, a lot of implementation challenges all along the way. And now they are even more vulnerable. And so a lot of the, there is a small attempt, and it's not always very successful, to organize community health workers and try to develop some sort of increased voice and campaign for them. But they actually are concerned, and they themselves have been told, if you don't come to work, you won't get paid. So they are very precarious in terms of their labor issues. They get paid 3,500 Rand, and that's what they're going to be using, like to risk their life. Some of them not anything at all. And I mean, we know with community health workers, that's actually, in some places, they volunteers only. But they've been reporting that given the fact that it has been such a top-down kind of situation with these command councils and lack of information, lack of involvement of community, that on the ground, the type of information that communities have is variable. There is just a dearth of good quality, like messaging for communities on the ground. And what happens is that you create a perfect condition for stigma. And community health workers have been accused of carrying the disease, And we know this from HIV. If a community HIV counselor came to my home, then people would be worried because they wouldn't want the rest of their community to know that they may be carriers of the disease. So they push these health workers away. So these concerns are just coming up again. And it comes up around, how can some community health workers be able to say that they've been given like 2 pairs of gloves and 1 mask and they don't get transport? They have to walk in the streets, and they have to continue doing this work. So it doesn't feel like, it feels like, a solution. Oh, we've got community health workers, the poor are taken care of. Let's not think about that anymore. Let's focus on the big issues, So to me, it doesn't feel like there's enough of a valuing of the frontline workers, be it community health workers, be it primary healthcare nurses, and we've got such a range of nurses. We've got enrolled nurses, now I'm forgetting. Anyways, we've got, and the one of the issues around nurses is that right at the beginning of the democracy, our nursing colleges closed. So the quality of our nurses at the front lines is also quite shocking. And this is the year of the nurse. So it's also another kind of struggle that we have is, are these nurses, do they have the capacity to deal with the issues on the ground? And when you're having, doctors and Glenda Grays and, these people with a lot of power and voice, taking up a lot of airtime, the struggles of these nurses, the struggles of community health workers, and these frontline providers get marginalized once again.
So like Russell was saying, whose voices are actually, being heard in this whole public discourse? Shehnaz?
You can carry on to the next slide.
Okay, so now
it goes on to just show from the similar. Oh, I thought there was a slide. Okay, it doesn't matter. Carry on. So in terms of the health system's barriers, I think that, yeah, this is the slide I was looking for. It's just a slide that shows the from yesterday, the Gauteng Department of Health demonstrating the stock on hand and the stock ordered. So, I mean, I think that this is demonstrating that, initially I think that the Gauteng Department of Health was really like struggling to put any systems in place, but it seems like they are slowly getting there. And this is one element of where they are sort of like beginning to share information, but it's very vague. It doesn't really show, and we don't really know who they're getting their stock from. So, but this is the kind of communication that they've started to put out. Yeah. So in terms of health systems issues, so there was a question about whether the districts and provinces have their own budget or whether it's just a centralized system. We definitely do have a budget, the national budget. We have a provincial budget. There is the provincial budget, the provincial departments of health manage the district budget. And then there's also a separate money that goes from treasury to municipalities. And municipalities are largely responsible for a lot of the primary health care. And we don't have many municipalities, but we have them across the big provinces. And maybe Ayesha and Russell can also just clarify if I'm saying anything wrong. But really here, the National Department of Health has made all these guidelines, and it seems as if there's a large centralizing of the whole COVID response in the state of disaster. But in the end, the provinces have to use their budgets and they have to actually implement. And having spoken to some people who are part of provincial departments of health, in Johannesburg and in Cape Town, they on the ground, doctors and managers are reporting that they want to do things, but then they get told there's no budget. So once again, when it comes to budget issues and the decentralizing of decisions, the decision space that people on the ground actually have, it's very vague, and it's not very, it's actually bad. It's not clear how these decisions are made, and often the provinces are also quite political, and the appointments for who becomes the MEC is quite political, and one of the major challenges that we've just come out of is the life many issue, which was a cost-cutting issue from the provincial government, which led to a disaster of people with mental illness being shunted out of private facilities into community-based mental health facilities, which were completely just actually dumping them into like homes in the community. So the province actually has quite a lot of to decide how the money is used. But districts are meant to have, it's also quite variable depending on where you go. So just to come back to the access barriers, with what Ayesha mentioned around, the fact that you've had this lockdown, it has created a lot of access barriers. And I think, I've spoken to, at the beginning of lockdown, to some doctors who were saying that the facilities in Gauteng actually closed. So people were being punished because nurses were saying things like, no, community members are just coming to get their immunization schedule up to date, or they're just coming for an outing into the facility, and that's just breaking the law, so they're closing things down. So it's actually been, quite a challenge. I think they've improved since, but there's definitely access barriers. People have reported not being able to access sexual reproductive health and rights. So there's a lot of things around the access barriers. And once again, the poor and marginal are most vulnerable. Then in terms of this issue of the private versus the public, and I think this is a critical issue in the South African health system, is that actually, the large majority of our money, of our GDP spend is part of the private sector, and it only serves 16% of the population, and the rest is public sector, and it serves the large majority. And what happens now is how does the private and public sector actually work together? And there has been lots of discussion and conversations. In fact, a lot of the private sector have been allowed into the command council and part of these decision-making processes. But actually, Russell put an article out today on News 24 showing that the department has offered private doctors and specialists 2,493 per diem rate for their services, including extra costs like intubation. They treat state patients in private facilities. And they've been willing to pay, like 6,000 Rand a day. And actually, the private sector have refused. So it's a real problem, because what do we actually do when it comes to deciding how do we equitably use the resources? How do we use the ICU beds? I think that, this is, and I spoke to one of a colleague of mine who used to work at the Red Cross Hospital, and for him, it's like a kilometer away is a private facility, and he worked, children, the ICU beds were all full, and he knows that the private facility, there are beds available, and he can't, send the child to those private facilities. So I think what the point that he was driving home at this point is that how can it be normal? Why have we normalized the situation of having these public and private healthcare systems that exist? And in this time, we need to start questioning the normalization of this private-public divide. And we do need to move towards a universal healthcare system. Yeah, in terms of the district health system, there's, our utilization rate just in normal times is quite low. People generally bypass the primary healthcare facilities and go straight to the tertiary hospitals. And so the district health system isn't in the best shape, and it is going, the cracks are going to show now. Yeah, and I think I'm just going to leave it there because we've covered all the other challenges. And like NHLS capacity is just that the results of the COVID tests are coming in quite late. So what does that mean? Yeah, so we can move on. And then, I mean, I just brought up this issue of mental health, and I don't know that there's enough data, but there was this one study that did look at what are people feeling around COVID, and the mental illness is definitely being driven from a social perspective. And I think, you know, this is something, to me, this COVID crisis is not just a health crisis of like a clinical crisis, it's definitely a mental health crisis. And, you know, South Africa doesn't have enough resources. Our mental health care is quite ancient. It's you know, it's a legacy of apartheid. We haven't really moved to a strong community-based mental health care and situation. And actually, you know, there's still a heavy reliance on psychiatrists and psychologists doing individualized care, and there's not enough kind of, you know, structures and supports to, you know, to really support communities who are struggling. And of course, a lot of the mental illness is driven by social determinants. And we know that, you know, we've been talking a lot about how these things are a big problem. And then in terms of gender violence, it's quite interesting when I was, you know, like having, you know, listening to the feeling on the ground, you know, there's definitely amongst healthcare professionals this, and even just other kind of NGOs, that gender violence is a huge concern. But when I looked at some of the reporting figures, it shows that there is underreporting, you know. And so I don't know, as someone who's worked in a very vulnerable community, I know that these women are going to struggle to go and report, because they're going to be scared to leave their homes. They're going to be living with probably the abusive partner. And I think it's just something that's going to be a huge issue that we're going to start. And actually, the president mentioned in one of his addresses that men have waged war against the women in South Africa. But I still am not convinced that there is enough to support this issue.
Shehnaz, it's the whole thing of societal violence, right? Like we had the apartheid police brutalizing our men, and they come home and brutalize our women, right? So we play out what we see happening around us, and it's such a terrible feedback loop, right?
I don't know, Ayesha, I think that argument stands, but I think sometimes that argument does give men a kind of excuse. Oh no, you guys are, you know, you've been traumatized, so yeah, it makes sense why you would beat women. And I don't buy it. To me, it's also the alcohol thing, right? Let's not give people alcohol because they're going to be abusive. It's sort of, you know, it's makes the association between alcohol is the cause of men's abuse. Well, actually, I don't think so. I think it's, you know, it's women drink too. Lots of women drink. They're not as abusive. To me, there's a much more systemic issue, and we can't make these reductionist arguments. I do agree that, I mean, I'm not saying that alcohol isn't an issue in violence, but I think that we've got to be careful around how we frame these issues. That's important to me. Yeah, and I think, you know, just an issue that concerns me is also this thing about the unpaid care work that women have shouldered through this coronavirus pandemic. And this is kind of cross-cutting across different, you know, classes, and I see it even with my own sisters who have children, with my own self, like all of us, women are carrying a much bigger burden of unpaid care work in the homes. And I think that like Oxfam has reported, that women usually bear the burden of these failing healthcare systems. And Mazibuko Jara, a thinker that a leftist thinker, I guess, his argument is that unpaid care work keeps the mining economy going. And so I think it's something that we just need to bring to our attention and be careful of, so that women are not left behind once again. Yeah.
I see, when I was reading up a bit about the basic income grant, it said that universal basic income, it said that this could go some way towards redressing that unpaid labor that women do in the home.
It's so insignificant. It's such a small amount that I don't know about that.
Yeah. So now moving on to other key issues. So it's not all doom and gloom. I mean, well, largely, but we have large pockets of community organization from within the impoverished communities. And I think also in many ways, it's like giving the communities a sense of how much they can accomplish when they really have to. So for instance, this morning, there's a doctor, a friend of mine, Leanne Brady, and she's working with the Cape Town Action Network? Well, they basically-
Cape Town Together.
Cape Town Together.
Community Action Network.
Community Action Network. So maybe if you know a bit more about that, you can mention that. So I'll just give a quotation that I found here. There's a member from the Bishop Labour's Action Committee, and we've yet to see the much promised food parcels from the government. And so feeding the most vulnerable is left up to community-based organization with very little, if any, financial support. Black will continue to do our best, but to say we are worried is an understatement. If we don't get enough food into our area in the next 30 days, we predict food riots and a violent protest from the state, a violent response from the state. So,
yeah, I mean, in terms of the community action networks, there's probably around 80, and it actually, so Leanne and a friend of mine, also Kense, they were part of this group that just decided, we need to kind of come together in Cape Town and think about these social issues that will emerge. And they developed a kind of like protocol for community action network, and it just mushroomed. It kind of, some of the community action networks are built upon structures that have already existed for years, and some of them are somewhat new. They actually do. Kenzie runs a kind of mental health peer support network. So she trains some people to think about addressing mental health issues, and then those people go out into their community, into the cans, and then they support others. So it's been really interesting in the way that the cans have emerged and have taken up issues that are very much contextually specific in the communities. Obviously, cooking food is a huge activity, trying to address issues of drugs and other social issues. There's been like people looting of food vans that have coming in. So they've been dealing with security issues. But I think to me, they also need to work a lot more with kind of community health workers and the state. And in a way, I feel like and I was having a chat with Ken, says the burden on the cans is another way in which women shoulder the burden of the state instead of, pushing for the state to do these things. So I think we do need to be careful, and it's amazing how the cans have developed, but I'm not sure it's sustainable because people are getting tired and there's a lot of burnout. Yeah,
sure. And Leanne mentioned that she had experience with the Ebola epidemic in Sierra Leone, and she said that, like, what would you rather do? In her article, she did it with a co-author. Would you rather have this sterile tent set up where people are sort of coerced into, and there's no trust, there's non-compliance, or could you create community-based safe networks where people are receiving personalized care? And sort of, well, she's working on both, right? She's working in the public health system and also on the community level. And so trying to anticipate what could we do on a community level to help people weather the coming storm. I'm just going to talk very quickly about patents and intellectual property. Well, when and if treatments and a virus becomes available, will it be affordable and accessible to developing countries? So we can't count on that. There's been historic inequality in resource sharing between the global north and south. We look back to the case of Indonesia and around H1N1, everyone had to share their virus samples, and Indonesia had a particularly valuable one. And these virus samples were then given over to a private company to develop vaccines which were inaccessible to Indonesia. So Indonesia held back on sharing again and said, no, until you make it affordable and equitable, we're not going to share. So in sharing our information, is this going to be allowed to be used widespread, across the board, or will there still be these inequalities? And when there are these inequalities, advocacy groups like MSF have been calling for governments to apply a leeway in international trade laws, which allows for waiving intellectual property rights. And this is known as compulsory licensing. So there is this leeway, and governments should take advantage of using it during a crisis time, because I don't think we can rely on multinationals to be generous during times like this. If you follow the Gilead and Retinova story, they are not outright saying that we're going to waiver intellectual property rights around this. So Shehnaz, why did this slide coming up? I don't know. Okay, I think this slide comes after the next one. Now we're looking at a way forward, right? Obviously, in the medium term, we need to fund this. Somehow this, we need funding for these medium towards long-term measures. And the challenges that one analyst mentioned was like, unlike wealthy Western countries, South Africa has less resource per person, less flexibility in its public finances, and it receives less generous treatment in the global financial markets. For example, like it was obvious public sentiment that in the beginning Ramaphosa inspired confidence, but the rand doesn't go up as much, you know. But like the U.S. is in shambles, but the dollar maintains its weighting in the global financial markets, right? But if we look again, here's the macroeconomists might want to come in and explain a little more around this, because what was mentioned was that now is the time for unconventional monetary policy. They mentioned the Reserve Bank providing helicopter money. To me, it sounds a little like quantitative easing, which has the knock-on effects. But really, I'm shooting a little bit in the dark around this, and I really hope some macroeconomists will come in and tell us how we can make funding or financing available from a macro economic perspective. But apparently, what South Africa is still doing is going along a very conservative route. It's not. Apparently, looking at its overall government balance sheet, we're rather considering going to the IMF for small loans rather than using other mechanisms at our disposal. I think this is a very important point, and I think it needs to be researched further, but unfortunately, it's beyond the scope of what we could do here. Shehnaz, do you want to speak a little bit about, just before you go into the wealth tax, I'll just steer, you added a point, stop sending money offshore. It's interesting, South Africa did have relatively protective financial flow controls. And just recently, some legislation has been passed easing up these controls, maybe to make it, as they say, more attractive to investors. But there's been some easing up on this capital flows, offshore capital flows. So that would be interesting to note in this time. Shehnaz, do you want to go into the wealth tax?
So, I mean, it's just actually an article that I've quoted from somebody who is a researcher at the Southern Center for Inequality Studies that showed how much money we could actually get if there is a wealth tax. But I don't know if there's an appetite for it. I don't think there's an appetite for it. But actually, it would be amazing. And I wonder if, you know, others in this group can actually shed more light into how we can, you know, make this more of a campaign or demand, because yeah, I mean, it's quite, and like when you think of even the president's brother-in-law, Patrice Motsepe, he's one of the, big wigs that have donated loads of money to the Solidarity Fund. But, I don't really know how much he's being taxed. And I think it's actually just a big issue. And maybe even Russell can come in here. But I'm not going to say more than that.
Okay. But just, I think, Shehnaz, it's fascinating that at least issues like the wealth tax and like universal basic income have entered the public discourse in a bigger way, or it has a space to enter the public discourse in a bigger way. Besides, like, for a long time, it's been on the fringes, Then now we're looking towards, if we look at a way forward, both in South Africa and globally, and even us in our middle class settings, like closed up in our houses and being away from broader society during this time, we've got to ask ourselves, like, what does it actually entail to stay alive, aside from the issue of self-actualizing, and when we can refer to Maslow's hierarchy a little bit, what is actually the necessity? And it's food, water, shelter, and health. And ideally, if we're working within the premise of a nation state, we should be able to ensure this or secure it. And some very poignant words came from an article by Richard Pittas and Vijay Prashad. They say hunger is amongst the most urgent of human needs, and immediate steps need to be taken to get food to people in this crisis. But it's also vital that the social value of land, rural and urban, the means to produce food, such as seeds and fertilizer, and food itself is affirmed and defended against the socially ruinous logic of commodification and profit. And we'll talk about the commodification of food a little later, and profit okay. Hunger stalks the planet because so many people are dispossessed. If you do not have access to land in the countryside or in the city, you cannot produce your own food. If you have land but no access to seed and fertilizer, your capacity is a farmer constraint. If you have no land and you don't have money to buy food, you starve. And they proposed, they said, looking at farmers around the world and what crop growers have said, that these are some of the issues that you can look at when considering securing or gaining control over food systems. As an immediate term solution, they said emergency food distribution. Surplus stocks of food controlled by government need to be turned over to combat hunger. They need to use their considerable resources to just basically feed people. Expropriate surpluses of food held by agribusiness, supermarkets, and speculators, and turn this to food distribution system. Feeding people, it's not enough to distribute groceries. Alongside public action, you need to build chains of community kitchens where people can access food. And we see this, or we saw this happening in the example of Kerala, where there was actual community kitchens and actual feeding of people. Then farmers who face challenges to harvest their crops must be supported by government. Living wages must be paid to agri workers that haven't been paid during this great lockdown. There is no sense in looking at workers as essential during emergency, then disdaining their struggles for justice in time of normalcy. Encourage financial support for farmers to grow food crops rather than non-food cash crops, because farmers in poorer nations are producing cash crops that rich ones can't grow in their climate zones. Reconsider the entanglement of the food supply chain. So to try to reconstruct food supply chains around regions, not across the vast globe, which will reduce the amount of carbon. Ban speculation in food. And I think this is such a big thing, the way in which the world of finance has enmeshed itself into the food supply chain by distorting food prices and supply and demand around speculation. The nitty-gritties of that, I think, sound fascinating, but unfortunately, I don't fully understand it. And maybe we can do like a follow-up session on food security. Then communities should have direct control over the food systems in which they live. Then we're looking at water. Again, it's a basic necessity to have running water in like 50 years post-democracy. Homes and shelter, it was one of the big promises made to people post-democracy. There was the issue of RTP housing. And I'll be honest, I don't know how far along we've come with that. There's also a call towards conceptualizing the inner city in a better way. Again, our cities are also set up along apartheid lines, and now again along class lines. Leanne Brady, again in her article, says to reimagine public spaces which are community-led and supported. And this is an example, a concrete example from the Cape Town Action Networks. In Lavender Hill on the Cape Flats, for instance, a field commonly known as the Battleground, the Cape Flats is notorious for gang-related violence. It is quickly shifted from a place where gang disputes were settled to a safe space for children to get lunch. The Lavender Hill Community Action Network started cooking for kids who no longer get their meal a day while the schools are closed, and have transformed this public park from a place of war to a place of possibility, where hundreds of kids come every day and eat lunch together while keeping a safe physical distance apart. We're looking at the concept of universal basic income, and it would provide basic economic security to each individual. So regardless of means testing, at regular intervals, no direction and restriction. The commentator that I read said recommending at least 1,280 per month, which is the upper bound poverty level to meet the basic needs. I think let's round up. Universal healthcare, I think Shehnaz, we spoke about a little bit about that when we're talking about the NHS.
Yeah, I mean, I think I'm sure like people want to go onto the discussion, so I'm going to try to be quick here. We've spoken quite. Have you?
Sorry. Yeah.
I don't know where the slide is now. Yeah, so I've spoken about most of these issues. I think the main thing for me is that we've got to move towards a much more equitable response. And, you know, South Africa has been moving towards a national health insurance policy, which is our version of universal health coverage. And I think that it's become more urgent now than ever. Yeah, we can just move on. I think we'll, yeah.
Okay, moving on. So just in terms of governance, and we've spoken a bit about this, where this concept of social solidarity, it's kind of broken down in the South African context, especially around the socioeconomic inequalities that continue to divide us. This is true spatially, psychologically, socially, and politically. And the government speaks, or the president spoke of rebuilding or building a social compact around COVID. But what would this entail? And very immediately, it would be a two-way communication with citizens participating in solutions. So while it seems idealistic, this is exposing all the breakdown in the structure, and we need to see how we can rebuild this social compact. On a broader level, just this is the last slide, there was an article that outlined 4 possible futures, where you have state capitalism, where you go down this route that perhaps America would be going down, where it's this extreme individualism, prioritizing exchange value, and we can see how it doesn't work in anyone's interest. Then we go to, oh no, that was the barbarism, right? The state capitalism maybe is where we kind of at. Then you go to state socialism, which is centralized response, expanding the social safety nets, which is what we see happening in a few of the success cases. Then we got mutual aid, where these decentralized responses, prioritizing protection of life, these community-driven governance structures. How will it all play out? We don't know. The author of this paper, of this article, said that he sees it as he'd hope for a mix between mutual aid or state socialism, but across the globe it could play out in any way. How it plays out in South Africa, I don't know. And it will have to be a very conscious effort at not going down the route of state capitalism to barbarism. Yeah. That's it.
Brilliant. Thank you so much, both of you. This has been a real masterclass in everything that is going on across South Africa. And I think it's been really, really interesting to see such a broad range of issues brought together in one presentation. And well done for everybody. I think we got about 25 people who've managed to stick with it through the 2.5 hours or so. So good job. I know a few people have dropped off, and they've said that they really enjoyed it. So I think I'll let you both share the discussion, and if people can raise their hands, and then Ayesha and Shehnaz can pick you as you have your questions. I think there's already a number of questions in the chat, which some of which you've addressed partly, some of which you haven't. I have a number of questions, but I'll save them and let's see what people have to say.
Should we start with the chat, or should we start with any? Does anyone have any questions that they'd like to?
So Alia's asked, can either of you comment on the proposed trial of an Oxford University vaccine in South Africa? There are concerns of, once again, unsuspecting populations in the global south may be guinea pigs with insufficient safety procedures built into these trials. I can't comment on that, but I know that, there are quite a few studies that have been, swiftly passed through the ethics bodies at universities, and it is something that we probably need to look out for. Yeah.
And it goes back to that whole issue with those French doctors saying that they should test out, do some trials in Africa, right? And the backlash against that. But it's nothing new. I mean, yeah.
Sorry, that was Ayesha Kaji, not Alia. Sorry.
Oh, Ayesha. Oh, great.
Okay, there's someone had their hand raised. Russell.
Okay, I'm going to unmute myself. Okay, firstly, thank you very much for a compelling and very wide-ranging presentation. And I think it sort of paints out the picture that many of us are sort of reflecting on, is how do we take 300 years of oppression and solve it in a couple of months? South Africa is one of the most unequal societies in the world, right? We have an unemployment problem where, let's say, almost like 80% or 60% of, after this, probably 80% of Black youth joining the ranks of the structurally unemployed. We have an economy that is structured to really just set up services for the 20%, and our government budgeting is set up in such a way that we just perpetuate poverty. So when we start thinking about a new deal that comes out of a post-COVID society, I think we need to disabuse ourselves from the current frameworks and really start thinking about the problem in a more holistic way. And I think one of those ways is really strengthening universal basic services. And by defining universal basic services, including in education, I think Shehnaz mentioned the growing inequality within our education system, which in many ways mirrors our health system. We have quintiles of schools, and the poorest have the least resources and the poorest teachers. So, and our grant system is set up in such a way that people are really destined to a lifetime of poverty, and there are no pathways out. I think in terms of the ongoing response to the pandemic and some of the social ills, I have a huge problem with the villainizing of the state, particularly by the broader commentariat, where we tend to place the burden of a response on the state rather than on a society, which includes how we organize business and how business responds to a broader social issue. The future of the pandemic remains uncertain in our country. We've like I've mentioned earlier, we had sort of this first wave of infections, and that's being largely contained. And now in the Western Cape, I mean, last night the minister said that the vast majority of positives are Black people who have limited access to healthcare, a public system that's on its knees. And, we really need more innovative solutions rather than just problematizing things that have been a problem for us since the dawn of democracy, right? We need short-term measures that address income and food insecurity, but we also need a longer-term plan that stops us being the custodians of the poor, but really start looking for ways and means to create sustainable pathways to employment. And I think through universal basic services, which is about improving state infrastructure and for the state to become an active player in making sure that its purchases and its investments are centered around not creating work opportunities, but creating pathways to skills and pathways to employment. But I don't think we should continue to problematize the poor, right, as being this huge thing that we need to try and fix or provide for, because it's something that intellectually I'm still trying to figure out and what our response should be. But I am concerned that we continue to think in the ways that we did when we created a problem. And I don't think we're going to solve it by continuing to think in binaries. The chance that the world will have a socialist system is highly unlikely because capital is strong. So we need to find some kind of hybrid measures that helps us to find a common ground that can take us forward. Thank you.
Thanks for that. Nice.
Iqbal,
Yeah.
can I come in?
Okay.
Uncle Iqbal. Assalamu alaikum.
Don't worry. Thank you. This is not, I'm very pleased to have this 2-hour session on political economy of South Africa. Obviously, COVID has made us all realize the broader aspects of this issue, right? So we have to understand that there are lots of issues, but as Russell said, this is not something we can solve in one go. This is a big, big issue. But let us pick up very bite-sized interventions which we can make. The first one is to learn from experience from a number of African countries. I think I saw studies that Ethiopia especially is doing very well in terms of its community, health worker deployment, controlling, testing and tracing and helping. So the death rate and the infection rate in Ethiopia is very much more contained. And that is a very relevant experience for South Africa. The second, which was quite an interesting intervention, was from the Finance Ministry of Togo, who have actually used a 2G mobile framework for distributing financial assistance, thus bypassing the banking system, existing problematic systems which take out the informal sector, and also internet access, because 2G is much more widely available. And 2G mobile technology now in Africa is quite common. So I think we should probably pioneer that again in South Africa instead of looking at 4G solutions, which will only work in Stellenbosch and Wits, nowhere else. So we have to be careful on that. The thing is that look at some countries where life expectancy has improved dramatically. And here I'm talking even of countries like Iran, for example, where life expectancy is now reaching 75 and 78 for men and women, from about the low 60s 15 years ago. The elements there are obviously access to clean water, access to universal vaccination programs, and so on. And South Africa ground situation is not very different from Iran 20 years ago. So I think we need to learn from them how they have managed this huge improvement in life expectancy, despite obviously being under very stringent sanctions from all over the place. The other thing is that there are good studies at the South Center, Third World Network, and UNCTAD on the patent legislation, compulsory working of patents, all kinds of things, where the contributions from India, Indonesia, and things were very, very useful. And you can log on to the South Center site and see how this works. Probably South Africa will need to do that. In your experience on the deployment of HIV treatment plans and the cost of that is quite valuable there, but I think that is nothing compared to what is coming for a potential vaccine for COVID-19. I think distributional equity will be a key element. You already see that the United States has withdrawn from WHO. Part of the agenda behind the scenes is that there is no distributional equity in vaccines. They want to monopolize that and also capitalize on that. And finally, on universal basic income or universal basic services, however you want to approach that. It is interesting that this debate is revived now. And parts of Spain, I think two regions of Spain, just yesterday have introduced universal basic income, albeit as a low level. But this is a solution being talked about. I mean, in the UK, we are finding that about 4 million people are falling outside every assistance which the government can offer. There is no way we can reach them because they are either in formal sector, not connected, not on any database or nowhere else. So how are we going to assist them? And that is where universal basic income comes in. And you can tax the higher earners, tax the universal basic income away. That is an easier way than not listing it widely enough, right? Lastly, on the question of capital flight, it is quite interesting. About 15 years ago, we had a discussion with the Treasury in the UK. And I said to them that you have now developed systems where you can trace small amounts of terrorist funding globally. Why can't you trace capital flight? And there was a huge silence in the whole room because obviously the capacity is there, the will is not there. So we just need to find ways to create the will so that money doesn't flow out into offshore accounts and so on, untaxed incomes and all kinds of influences which come. And South Africa has nothing. I remember that when this Nigerian president, Sani Abacha, died, his chauffeur had $40 million in his London, UK account. Okay, so it's something which is horrendous in terms of the amount of money which is siphoned off, and I'm sure it is continuing now. So I think these political economy questions are always there, and as Russell again said nicely, we can dream about having a socialist state, but really the idea is how to find a better balance between state and private organizations. And here the key is to see that the private organizations are not made for taking risks. Risk is part of privatization, and they should suffer the consequences of risk. Whereas if the state takes on the risks and gives the benefits, which is like socializing loss and privatizing gains, then we are in trouble. So we have to balance this, and all the lobbying and advocacy must be to dig out how we subsidize risk of privatization and say we shouldn't be subsidizing them. If they are private, private. If they are public, they are public. Fortunately for South Africa, at the moment, the fall in oil price gives a little bit of a flip. So you might not need that much external money as you would have needed even 3 months ago. And there is a window of opportunity there. But I'm glad this debate is beginning. COVID is focusing our minds on this basic division in society between the haves and have-nots. But also it reinforces that the haves have a critical reliance on the have-nots for their survival. Thank you.
I don't know if Ayesha Kaji is still around because she's got a lot of experience having worked across the continent, and maybe she can come in and also talk to some of the issues that she raised in the chat. Is she here? No, we've lost her. Okay.
Ayesha,
Okay, we've got Oshima.
Yeah, thank you, Ayesha and Shehnaz, for a wonderful, exhaustive session.
Can you speak louder, please? Sorry.
Hello. Hello. Yeah, am I audible?
Yeah, now you are. Thanks.
Yeah, what I'm saying is, thank you, Ayesha and Shehnaz, for that wonderful, exhaustive session. I don't know whether I missed something in between, but would just like to know if you could shed some light on the maternal as well as reproductive inequalities which are prevalent in South Africa.
Say that again, maternal and?
Reproductive
Oh,
health
yeah,
equality which are prevalent in South Africa. If you could shed some light on those aspects. Hello.
Shehnaz?
Hello.
Sorry, I was muted. I don't have the stats on hand. Ayesha, do you want to start? I'll just look for some stats.
I actually, right now, in terms of the clinical and public health stuff on the ground, I'm not too well informed about that right now.
Okay.
So actually, it would be
Look,
better.
I think I can maybe venture an opinion there. It's Russell here. Look, maternal and child health in South Africa is I think it's problematic in many ways because we still have quite high in facility maternal mortality rates. Right. I think we are having a challenge with vaccination coverage, which is declining, particularly amongst poorer groups. And I think, and one of the sad things about the lockdown is, and while we on the policy side, we have maintained continuity of care. I think the broader messaging around COVID has often resulted in people not going to clinics. So there's a paper out from UNICEF at the moment, and I think some other other papers also coming out talking about broader challenges that we'll face going forward. But maternal and child health continues to be a problem, and there's lots of variation across provinces. For instance, I think the maternal mortality rate in some rural provinces is like 200, whereas in the Western Cape it's closer to the global target of 80 per 100,000. So yeah, I think this is one of the challenges. I mean, with COVID, the challenges that comes is also with resource allocation. Much of the money is going to be going into hospital services. And given the way that we finance health in South Africa, primary healthcare services will probably have a challenge for funding. So part of our advocacy around a post-COVID or some kind of society is to start looking at how we can strengthen primary healthcare, particularly to ensure that we don't lose the marginal gains that we achieved in maternal and child health with the introduction of prevention of mother-child transmission. But yes, we do have issues with under 5 malnutrition. We have issues around under 5 mortality around with pneumonia and all kinds of stuff like that. So I think South Africa's health system was problematic going into this crisis. And I think unless we have really real measures to strengthen primary health care in the next 6 months or so, we are destined to have a much bigger problem. So the cost of COVID may be much more than just the mortality from COVID itself. Thank you.
Thanks, Russell.
Yeah, thanks. Thank you, Russell. Yeah.
Okay. I see Ned asked the question about the Western Cape, and I don't know if you missed that earlier. There were 3 theories being floated about, but I can review that a little later. Yeah. Is there anyone else? Yes.
I have a question. I'm sorry, it's Russell here again. I think last night we had quite a detailed presentation from the head of the from the Ministerial Advisory Committee. And I think one of the things that came out of that has a lot of people thinking today is the turnaround times in tests. So, and I think that's also one of the scenarios with the Western Cape where they've approached a more clustered sampling approach to testing, where they tested workplaces and areas where they identified infections and didn't really rely on community testing or contact tracing. So some people were of the view that their testing is what is leading to more positives. And then we have situations like the Eastern Cape where we are also not testing at the same rate. And there's something like 87,000 tests that are unprocessed. So this is obviously leading to a lot of chattering around the extent to which the virus is in the community and how much we actually know. So I'm curious as to what some of the epidemiologists in the group, if they have a view on the finding of cases and how it could speak to a broader epidemic elsewhere, and what are the kind of things that we need to maybe look out for that will signal that. You know, because I think that's particularly in the province where I live, which is Gauteng. We've been increasing our positives increase, in my opinion, at a very slow rate compared to how it's happening elsewhere, and it doesn't make sense given the way the city is set up. So I'd be curious to hear some views on how we can correlate those two, because the talk last night was to say that no, in fact, positives are declining outside of the hotspots. Thank you.
Do we have any of the epidemiologists on hand still? Or Mikdad, how's your knowledge around testing? No?
Okay.
Maybe
Kasia
we can.
seems to have a question.
Can I ask a question? So I was just wondering, I'm sorry if I missed this before, but I was wondering whether you could say something about who is dying from COVID in South Africa, because, you know, in UK, like Mikdad has done some work about BAME communities. And so the Asian community is dying disproportionately in the UK. There's also a link, obviously, with race and class. But from what I understand in South Africa, there's differences in terms of class. So maybe the Asian community is not as poor as the Black community. And so could you say something like, are they also disproportionately affected? So the Asian community in comparison to the white community, for example?
This is an interesting question because I haven't actually seen any stats disaggregated for race. So all we have is the regional differences or the provincial differences. And within that, there's a lot of inter-provincial discrepancies as well, but that's not coming out either. So we're just getting location-based stats. Shehnaz, have you come across anything disaggregated for race?
No, not recently. I don't, but I think that initially, you know, a lot of the infections were because of people coming from international travel. And then as we're going along now, there's a lot more local transmission. And I think that there's just not enough to know trends right now. But I mean, I think when it comes to the local transmission, it's also where are the hotspots. So we've been having some places in the Western Cape, even in Gauteng, where you know, like there's a special apartheid, so you actually have you know, a map, and you can almost tell what the race of the people that might live in those areas. But I think that it's too early to tell. I don't know, Russell, maybe you might know, but I agree with Ayesha. A lot of it has been around province and area, and not so much a race.
And I think the data coming out itself, it hasn't been as comprehensive as statisticians or analysts would have liked. Like even the provincial data coming out has been piecemeal, and yeah, it's not as extensive as you would find elsewhere, perhaps.
There is obviously, look, I think the data is maybe not being shared in a disaggregated way, but I agree with Shehnaz that when you look at how the thing is evolving, initially a lot of the deaths were concentrated amongst the white population, right? I think last night the minister said that the disaggregated data by race is not available, but he did make a statement that early indications are suggesting that it's predominantly Black, right? The rise in deaths now, you know, particularly in the Eastern Cape, where the epidemic is really concentrated amongst the Black population, or so-called Black, because it includes. But I think with Asians in South Africa, they occupy a much higher economic class. So yeah, I don't know. I haven't really seen anything specific around Asians, but it's a very small population group in South Africa. But based on what the ministers were saying last night, and I think what we will hear probably in the weeks to come, because there are increasing calls to share data by race. But I don't know. I think it may be problematic in a country like us, like ours, where the privileged classes may start thinking that it's not their problem anymore, and that the government must sort out the people that the government has to sort out, and that social solidarity that we saw at the beginning of the response is dissipating. In South Africa, like one of the big challenges that we face now, I mean, there was an article talking about the cost effectivenesses of field hospitals. But field hospitals also need to be manned by healthcare professionals. In South Africa, maybe 50% of doctors work in the public sector, right? And have no ways of really and then the other 50% work in the private sector. We're now having contract negotiations with the private sector, and influential private practitioner groups are refusing to sign off on the rates that we're being offered. And we can have as many beds as we can, even in field hospitals or in general wards. But if we don't have the human resources to service those beds, we might as well not have them. So I think the big challenge that we're facing now is to get back to social solidarity and getting people to negotiate in good faith, because we can nationalize the private hospitals, but we can't force the doctors to work in those hospitals, because none of our hospital groups employ doctors or specialists. So we headed for quite an ethical crisis when it comes to the delivery of healthcare. And in many ways, we are being held to ransom by the professional association, who refuse to accept the negotiated fees. How we will resolve that, I don't know. But I think that's the thing that, I mean, maybe because our projections came out recently and we're estimating 40,000 deaths over 5 months, any situation that you look at, even if it's a tenth of that, will place a strain on public sector capacity. And we need professionals to actually step forward and say, look, we're willing to accept lower rates, or we're willing to volunteer our services, or something like that, so that we can deal with the public health threat. Sad, otherwise we're going to get into a situation, unless you have access to healthcare or even ICU beds, will be determined on whether you have medical insurance or not. And I think that's the thing that's really troubling us, is an aspect of it. As much as there's a whole lot of socioeconomic consequences and impacts, this is still primarily a health threat. And we're not out of the woods with the health threat yet. And that's where the structure of the South African health system is becoming a problem.
I think also, just to add, like recently there was a health market inquiry into the private and healthcare system as a whole. And I mean, it was clear from the report that the private sector is unaffordable to most. It doesn't provide sufficient coverage of care, even for those who have medical aid. It causes a lot of catastrophic expenditure for people who need to use private facilities, and the burden of costs outside of just the health care that people end up facing. And so we have this assumption that private is better, but it's actually really not. And most people run out of their savings account. So I think that, and unfortunately, as Russell said, most of our healthcare professionals move from the public sector to the private sector, because that's where they earn better. That's where they can develop professionally. And this is across, doctors, allied healthcare workers, pharmacists. You have very few doctors that want to remain in the public sector. In the dental healthcare, we don't even have that as a kind of public sector, issue. So I think, the debates we've been fighting on the NHI, if you look at the media coverage, it is atrocious, because most of the media houses are owned by these private corporates that have been trying to, say that government can't administer the NHI, it's going to be a disaster, our healthcare is going to be so low. And so we have a really bad, and we have an issue of language. We have this issue of calling it universal health coverage, which implies an insurance, which implies, it's got connotations of what, of insurance companies and exploitation. So people don't really understand that that the NHI policy is trying to pool funds and try to nurture universality and social solidarity. And it really looks like it's just going to crumble and die. So I think, well, just, our private health system is just going to collapse. And so there's a lot of fear from those with money and power, a very small population of our country. So I think that COVID also starts to open up this truth telling that the private facilities have a responsibility. What are we going to do? How do we ensure equity? What does it mean if my health, if somebody, in Site C in Kailicha or in Diepsloot where I used to work, is sick, as opposed to, just across the road where the Stain City is this, huge locked down area where people that are really rich live in a kind of very securitized, closed up community. Only rich people are allowed in. So all of these inequalities are really coming to the fore. And I just brought up this image. I don't know if you can see my screen, but it's one of the ways that the data that I have, because I really don't have a lot, but you can see there's all these green and blue and red bars. And the first one on the side is City of Johannesburg, it's Diepsloot, Kaya Sands. So there's quite a few cases there, but as you go further down, the highest green bar, 328 cases, is in Sandton, Orange Grove, and Houghton, and Alexandra. And Sandton is one of the richest areas of Gauteng, but Alex is also kind of poor. So, Alex and Sandton are right next to each other, and most of the cases are there still concentrated in the area. So it's very difficult to make out what does this data really mean and where are these people, and yeah, so I don't know. This is what I've got. Yeah, I'll stop sharing the screen now. Yeah, I mean, I think when it comes to, I think our data in any case in healthcare is not as robust as we would like it to be. There's a lot of challenges with our data, and we don't have as much data as the UK. I mean, in the UK, you've got phenomenal data. So it's very difficult to make these conclusions based on the data we actually have. Yeah. But I think that, like Ayesha said, at least, I think we, unlike, for example, India and Brazil, I think South Africa is not, there is commitment by the state to try to do something about COVID. It's not like Bolsonaro, who's been really bad. So I am a bit, not, I don't know, hopeful maybe, I don't know. I will have to just wait and see. But I do think that we haven't learned enough of the lessons, or we've like lost our memory of the struggle that we went through with HIV. And it seems like there's not enough of a civil society mobilization to really push back at government for some of these things, like the wealth tax, like better state financial, just to address some of these social issues that we've raised. And I wonder if that's gonna change. And I wonder how solidarity movements across the globe are gonna start to rise, because it's not unique to South Africa. But yeah, I'd like to see that happening. And yeah, let's see what happens. But I think around this issue that Russell just raised around doctors refusing the amount that government has offered to them, I'm hoping that that's something that will be a leverage point for the large majority of the country to say that's not acceptable. We need something. We need the private sector, and we need doctors to step up to the needs of our community. Thank you.
I think Ayesha has her hand up.
Oh, Ayesha's back. We were hoping that you can speak to some of the issues you've raised, and also some of the issues across the continent based on your experience. Yeah.
Hi, everybody. Thanks for a very informative presentation, both Shehnaz and Ayesha. I lost connection somewhere in between, so I missed some of the questions, but I've sent both Shehnaz and Ayesha and somebody else who asked for it from a bioethics company, I think, or organization, that advert from Oxford University, which appeared in the South African press. You asked something about Tanzania, I think, Shehnaz, or something about experiences elsewhere in Africa, if that's what I was getting from the gist of the little bit of what I caught of your question.
Well, Uncle Iqbal brought up some interesting points about how South Africa can learn from other countries like Togo and Ethiopia in how they have responded to COVID.
Right.
And I don't know enough, and I was wondering if maybe you know. But also, I'm sure you raised your hand because you had your own questions, so for your own contribution. So yeah.
Well, yeah, it was essentially on the breakdown by of COVID-19 cases by race disaggregation. I know from friends working in the sector that they're currently very, very frustrated that the NICD is refusing to release that data, either disaggregated by race or even disaggregated by geolocation, which means that, for example, at the provincial level, they've got to do a sort of track and tracing again, which the NICD has already done. It's essentially a duplication of effort, of time and resources. But the basis on which the refusal is being done at this point in time is that it's apparently an infringement of the right to privacy. And, we have quite stringent personal privacy legislation that's been recently enacted. And of course, the right to privacy enshrined in the Constitution. However, there is also the provision for the balancing of rights. And it seems to me really, really strange that state institutions or state-led, state-run institutions like the NICD are not sharing information with their partners in the health departments at provincial level and with their other sort of, state, semi-state and state-led organizations in the public health sphere. That seems to me to just be really a question of gatekeeping, rather than a question of really wanting to protect people's privacy rights.
Yeah, I agree with you, Ayesha, in terms of the reasons that they give for not making things more transparent are very weak. Yeah. Are we good to round off?
So can I just raise something about I think in the beginning you started with talking about these key expert and policy committees that have been influencing decision-making in South Africa. And one of the things, I guess, whenever those of us from outside South Africa think of South Africa as apartheid and then the kind of a very prominent position of white and Indian experts in either in academic positions or in policymaking positions, and even people like Professor Salim Abdul Karim and people who have been the face of a lot of this haven't been Black South Africans, and I don't know how is that just us seeing things from the outside? Is it, or do people in South Africa feel like the response is not maybe? And I think Shehnaz has already talked about the kind of overwhelmingly male composition of these decisions, but is that something that's of concern in South Africa? And is it something that makes measures proposed where people have to take voluntary action less likely to succeed if they don't feel like they're being spoken to from their own kind of perspective? And also, when we talk about these broader measures, like the economic measures proposed, the people who are making these decisions are the ones who are going to lose out most if any of those kind of big structural changes are made in society. And does that change the likelihood of any of those measures being seriously considered?
I'm going to divert this question to Ayesha and then I'll comment, because I think Aisha's best placed to answer. Ayesha Kaji, not Ayesha.
Brilliant. I was going to throw it back at you.
No, Ayesha Kaji, and then I'll say. I mean, our health minister is not Indian or white, and neither is our president, and they have been quite supportive. But yeah, Ayesha Kaji, you go for it.
Position, Shehnaz, I think Shehnaz or Ayesha, Jacub has posted a link to the composition of the advisory team or the advisory committee. But yes, the vast majority of experts in the field are still either white or Indian, not specifically Asian, because in this country, Asian also includes Far Eastern or Chinese, but certainly, of Indian ancestry or of European ancestry. However, as Shehnaz has said, we do have a health minister who is a qualified medical doctor, and a pretty good one at that, who is Black and has been largely the face of the COVID-19 response. If I'm hearing the question correctly, the question is, are people less inclined to take advice or follow the directives of people who don't look like themselves or live like themselves? Is that correct?
Yes.
So I guess there's two parts to it. One is that, and the other is, are people who live in such a different world and experience, who face, who would lose out from the kind of economic policies proposed to tackle this crisis, are they less likely to take those things seriously or implement such policies?
By and large, I think that while there's a small proportion of people who are less likely to take those policies seriously, I think by and large, many middle class, sort of from lower middle class upward, South Africans have taken the policy seriously to date. The real problem, the real challenge is the socioeconomic one. The huge housing density problems, the lack of potable water, all the things that Shehnaz and Ayesha have spoken to throughout this presentation. Those are the real issues. Those are the real challenges. And then add to that or twin with that the huge disparities between the public health sector and the private health sector. And the issue of private health professionals not wanting to come to the party in terms of serving communities at the kind of rates that government can afford to pay them. I think those are the major challenges, rather than people looking at the racial composition of the advisory committee, the ministerial advisory committee, and refusing to take advice based on that. However, because of that racial composition, there have been issues between different bodies that are contributing to that advisory committee. So for example, when about 10 days ago, when a prominent medical public health person actually spoke to the media in her personal capacity, what happened was that there was a very swift backlash, firstly from the minister himself, who reprimanded her, as is his right, even though she had spoken in her personal capacity. But then there was what seemed to be a witch hunt going on, coming from the Director General or the Acting Director General of Health, recommending that she be put under investigation and chastised, etc., etc. And that is really not the kind of politicking we need around this pandemic, given the very serious challenges that both Ayesha and Shehnaz have articulated today.
Yeah, I mean, to add to what Ayesha is saying, or even just to make it more complicated, I think that it's not so much whether people are going to want to listen to the rules or not. It's the fact that they actually can't. It's really difficult when you're out there in the communities. And it is about, why don't we have enough, if we are a democracy, why don't we have enough spaces where community voices can be heard? We have these like institution bodies within the health department called hospital boards and clinic committees. But these are really underfunded, underrepresented. We don't have enough of a complaint box. I mean, my experience working in the NHS in the UK was that if a patient complained, it was a big deal. It was taken seriously. I had a racial complaint against me once in the NHS, and it freaked me out for a long time, you know. And I know what it's like to be a patient in the NHS, where when you make a demand, people listen because it counts. Here in South Africa, people, if you want to complain about the health department, you're going to be scared because you won't get services, you won't get care. So the point is that the voice of the communities are really marginal. And when what Russell mentioned as well earlier is that, you know, he's part of the Rural Health Advocacy Project. I'm part of the People's Health Movement. We have the Treatment Action Campaign. We have Section 27, which is all these kind of these civil society groupings. Many of us struggle to really also access community voices on the ground. And these people that are representing, even for sexual reproductive health and rights, there's largely the face of white people or even Indian people who are part of these civil society groupings that actually don't have enough of a sense of what it's like to live and grow up and struggle in these marginal communities. So it just pushes the voices of the poor and the marginal even further back. And so, yeah, I think that's why I'm saying, like, I feel, you know, we need a groundswell movement. And the cans are great because the cans, they're actually really incredible because they're meeting the immediate need of so many people across Cape Town. And now there's even mushroomed into other provinces like Gauteng. But they sort of allow the state to be as incompetent. They aren't challenging and pushing back and really, you know, stopping things to say, we can't go on like this. We have to address the inequalities and we need to do it from a structural and systemic perspective. I don't know how we're going to do that. Yeah, that's I think something that I feel we kind of need to develop kind of global solidarity with other countries around. Really think about campaigns to you know, not to villainize government, as Russell said, but to make sure that we use our constitution and use it to protect the socioeconomic rights that are enshrined in our constitution. Yeah.
It's interesting, Mikdad raised a point there to say, interesting how majority community can be referred to as marginal. And that's just it, right? That's the problem.
Here we are sitting on Zoom talking about that. And again, it's like, you know, even within my own kind of, like, there's been a group of a C19 coalition, which has started, and there's a website you can go and have a look. And they call themselves the People's Coalition, you know, and what's interesting is that the People's Coalition has formed as a people's coalition where people, and they had a people's assembly, and there's been some issues within it, but even within the People's Coalition, they've come up with a kind of salary structure for some workers in the, and it was really low. They were like, you know, already structural issues around some of the workers who, so it's almost as if we want to have a People's Coalition, but we don't want to hear what the people have to really say in the coalition, you know. And even in the health working group, of which I am a part of, we've really struggled to get voices from the community. So and again, it is around, like, can people have data? Do people have smartphones? Do people have WhatsApp? Do they even have WhatsApp that can allow a few calls? How do we get voices? And it actually does show cracks in the so-called leftist movements that are seemingly so progressive in society, but actually I feel fails a large majority of people. Yeah, we need new ideas. We need new ways of thinking about what do we really want? What does health really mean? What does social solidarity really mean? How do we organize societies such that we think about using COVID as a moment to really reflect that, you know, you have a crisis of COVID within a crisis of the health system and education system and failing other systems, but in a broader crisis where climate change is here, and there's going to be a lot more issues that we have to face. You know, we've already had drought in South Africa. What are the other kind of climate change challenges that we're going to face coming forward, and how are we really preparing now to think not just selfishly about the I, but as a whole. And when you think of the education system, which is now even worse, I can't imagine what it must be like to be a young child and you can't get through your school year. You can't get your education. So for the future of, you know, who gets to tertiary, who gets educated, who gets to be making decisions, COVID is going to put us a lot back. If we, yeah, I don't know, it's going to be a struggle. Anybody else? Ayesha, do you want to add anything or comment on what I've said?
So maybe this is a good point to wrap up. I think it's been really, really fascinating. It's been a great presentation and a really interesting discussion. And I think there's so much more that can be said, that we could go on and on and on, but I think we need to draw it to a close. I think, and Ayesha, you've already been writing about a lot of these things, but maybe it's worth splitting out some of these issues into separate areas and then focusing down on maybe the issue and looking at how it's dealt with across the world, and different ideas around issues. Because I think this, I mean, one way to do it is this kind of broad view across one country, and the other way is to look at a particular issue across countries and try and get different ideas on that. And so I think we've done a number of these broad views across parts of India, different countries that we've looked at, Nigeria and other parts of the world. And so maybe we can look at that. So maybe, Ayesha, we can think about a set of areas that we could look at. Yeah.
I said, if anyone else is keen on jumping onto any of those topics and exploring it, either for popular media or for journal publication, just contact me, and then we can work at it.
And maybe
okay,
you want to just, maybe you guys want to just put your contact details in the chat, so anybody who doesn't have them, they can just get in touch. And hopefully you're happy to share the slides and you'll put them up somewhere online along with this.
I just want to, I think we should check the referencing, because I think we need to do proper referencing, and then we can definitely share.
So once you're ready, I think there'll be a lot of people who are interested in the details, and there was a lot of it, and I think it'll take some time for us to digest it more and then come back with more comments. So.
Cool.
Great. So with that, thank you all very much, and we'll see you next time.
Thank you.
Thank you, Mikdad, for this